Welcome you all. I am Dr. PJ Madam Rafi. Today we are going to discuss about anti-hyperglycemic agents. Okay. First in this group we have insulin releasing agents. In insulin releasing agents we have drugs like sulfonylureas and meglitinates. Okay. So in sulfonylureas first generation group will be chlorpropamide, tolbutamide. Second generation group, this is most commonly used drugs will be there. That is glipizide, glibenclamide, glicazide, glimepiride. Okay. In meglitinated group we have repaglinide, nataglinide. This both group will have same mechanism of action that we will see in this slide. Okay. So here main important things is, first of all we'll see the mechanism of action, then we'll discuss. In first mechanism of action, normal these drugs will are insulin releasing agent. That means they are insulin secretagogues. That means they will enhance insulin secretion. Okay. If you see in previous class in insulin, the how insulin will get secreted, the same mechanism these drugs also will act and they will enhance insulin secretion. Okay. So first of all, obviously glucose entry will be there with through Bluetooth transporter. This Bluetooth transporter, this glucose will be produced ATP. When this ATP will bind an potassium ATP dependent channel. So when obviously potassium ATP dependent channel will get blocked, obviously there will be more potassium, leads to more depolarization, which will allow more calcium intracellularly. This calcium will helpful in exocytosis of insulin. This is normal insulin secretion mechanism. Okay. Where these drugs will act will here will be, here these drugs will act, that means sulfonylureas and meglitinides, they will block this potassium channel. Okay. Obviously when they block potassium channel, there will be more accumulation of potassium inside the cell. Okay. That is one mechanism, because obviously here ATP also is blocking potassium channel, thereby raising potassium level. So obviously by raising potassium channel, obviously there will be leads to more depolarization, more calcium influx. That is normal mechanism. Here exogenously we are giving sulfonylurea drugs. These drugs are blocking this potassium, ATP dependent potassium channels. Obviously when they are blocking externally also, what will happen? There will be more retention of potassium. Obviously more retention of potassium will cause more depolarization, more influx of calcium, more releasing of insulin into the circulation. Okay. This is how the mechanism action will be there. So here in this, one more important drug, one more important thing will be chlorpropamide. Okay, this chlorpropamide is the first generation sulfonylureas. They will have ADH like action. Okay, that is the main important characteristic of chlorpropamide. Next thing is, in next second generation glyc, this glicazide glimepiride, they will have antioxidant property. Okay, this is a recently repeated MCQ in INICET. Okay, so which of the following sulfonylurea drugs will have antioxidant property? To means glicazide and glimepiride. Okay, you have to remember. That's all. Next. Next group will be bigonides. In bigonides, we'll have metformin and fenformin. Metformin is the most common used drug in diabetes. Okay, what are the mechanism of action? These drugs decrease blood glucose by activating AMPK receptor. That means adenosine monophosphate activated protein kinase. Okay, how they will control glucose? That means they will help in decrease gluconeogenesis. That means no production of glucose and increase utilization. Obviously they are decreasing production and increasing utilization by skeletal muscles. Okay, that means obviously blood glucose will get fall. Next one is, if they decreasing, that means they're slowing of glucose absorption from the GIT. Obviously one thing is they are utilizing more glucose. Okay, second thing is they are decreasing the absorption, obviously glucose level will fall. Next, that doesn't increase serum insulin concentration because it is not a secretagogue. Okay, these drugs are not insulin secretagogue. They won't increase insulin secretion. Okay, that's why these are the first choice of diabetes mellitus. Why? Because three mechanisms. Okay, first thing is decreasing gluconeogenesis, no production of glucose, increasing glucose absorption. Okay, that means increase glucose uptake, not absorption. They enhance glucose uptake. Second thing, third thing is they decrease absorption from the gut. Okay, one thing is inflow is decreased, production is decreased, but they use more glucose in the available glucose. Okay, thereby obviously final product will be hypoglycemia. That means they reduce glucose level in the body. Okay, that's why these are the first choice of type 2 diabetes mellitus. Okay, next group will have alpha glucosidase inhibitors. In this group drugs will be acarbose, miglitol, oglibose. Okay, this alpha glucose is an enzyme. It will facilitate digestion of the complex molecules to simple molecule. Okay, That means polysaccharides to monosaccharides. They will digest the food. Okay, so once they will digest the food, obviously glucose will get absorbed. Okay, when these drugs are, that means these alpha acarbose, miglytal, oligobose drugs, these are inhibitors of alpha glucosidase. When they inhibit this enzyme, obviously there will be no conversion of complex to simple molecule. When there will be no conversion, obviously what will happen? There will be no absorption of glucose. Okay, leads to hypoglycemia. That's why they reduce postprandial, means after lunch, after food, hyperglycemia means they won't convert the complex molecule to simple molecule, so they won't be convert absorption of, obviously there will be no conversion of glucose, so there will be no absorption of glucose, leads to reduce postprandial hyperglycemia. Okay, here the main adverse effect of is flatulence. They will form more gas, diarrhea, abdominal pain, because of obviously there will be no conversion of complex molecule to simple molecule. So these are the contraindicated inflammatory bowel disease because of more flatulence. Patient will have more irritation, then diarrhea, abdominal pain because of the thing. We have to avoid in IBD condition, and intestinal obstruction because they will enhance intestinal obstruction. Okay. Next group is thiazolidines. Okay, these thiazolidines means also known as glitazones. Okay, examples will be pioglitazone, rosiglitazone, togrelitazone. Their mechanism of action will be they will act against this PPAR gamma receptor, peroxisome proliferated activated receptor gamma receptor. Okay, they mainly located on adipose tissue, skeletal muscle, and liver. Okay, next is they enhance peripheral uptake and utilization of glucose. That means they will enhance more peripheral uptake of glucose. Then obviously decrease gluconeogenesis. No production of glucose will be there, and they are increasing peripheral uptake of more glucose. So thereby obviously reduce glucose level in the body. So mostly used in insulin resistance patients. Okay. Next is ingredient mimetics. Okay, in ingredient mimetics we have exenatide, liraglutide. These are the group of hormones, that means they will secrete along with insulin in the among with GLP-1, that is glucagon like peptide 1, and glucagon insulinotropic protein. Okay, polypeptide. Among these two hormones, it was released into the circulation. These are released from upper and lower GI meals, which will enhance insulin secretion. That means these are insulin secretagogues. Okay, they will enhance insulin secretion, thereby obviously decrease glucose in the body. Okay, so what are those ingredient mimetics? Like exenatide, liraglutide. Okay, next group is DPP4 inhibitor, that is dipeptidyl peptidase 4 inhibitor. In this group, drugs will be sitagliptin, saxagliptin, linagliptin, vildagliptin. Here most repeated MCQ will be which among these DPP4 will be safe in renal diseases, that is linagliptin. Linagliptin will be safe in renal disease. This is repeatedly twice. Okay, in INI set. Okay, here main thing is they will increase insulin secretion, decrease glucagon release, delayed gastric emptying, that way finally suppress appetite and weight. Okay, these DPP4 inhibitors are very important. You have to remember the names. Sitagliptin, these are gliptin drugs. Okay, sitagliptin, saxagliptin, linagliptin, and vildagliptin. Among these things, linagliptin will be safe in renal disease. Okay, next. Next group will be amylin mimetic drugs. These are all recently new developed molecules. Okay, they will be different molecules. They will act by different mechanisms. Okay, amylin mimetic drug means it is pramlintide, only one drug. That is the only drug, oral drug, which will be used in both type 1 and type 2 diabetes mellitus. This is an MCQ. Which drug will be beneficial in both conditions? Type 1, type 2 is pramlintide. Okay, this pramlintide will be the only drug which will be beneficial in type 1 and type 2. It is secreted along with insulin, inhibit glucagon secretion, delayed gastric emptying, and suppress appetite. These are the actions of this pramlintide. Next, last and most important will be sodium glucose co-transporter inhibitor, that is SGLT inhibitors. Okay, in this among recent development drugs, these are most commonly used nowadays because of their beneficial effects. Okay, so these SGLT inhibitors we have dapagliflozin and canagliflozin. gliflozin. Okay, it is dapagliflozin and canagliflozin. These are the important drugs. They are most commonly used nowadays. They have different uses. Okay, that means how they will act means they inhibit reabsorption of glucose. Okay, so this SGLT will be located in the renal tubules. Okay, when kidney will be filter glucose, it has to be absorbed. Okay, it has just absorbed to the this sodium glucose transporters. Okay, when you are inhibiting these transporters, obviously there will be no glucose absorption. It will be causes excretion of glucose, thereby decrease body glucose. Okay, so thereby these drugs will inhibit reabsorption of glucose in the proximal tubules. That way, obviously, they will reduce the glucose level in the body. So, what are the major advantages of these glucose transport inhibitors will be? First thing is weight loss. Second, obviously, more glucose will be flushed out. So, hypoglycemia. Next is improve insulin resistance. Okay, because why here no hypoglycemia means they are excreting excess glucose, not normal body maintained glucose. Okay, because these transporters will excrete excess glucose only. Okay, so thereby obviously there will be no hypoglycemia will be there. Okay, next improve insulin resistance will be added advantage. Main disadvantage of this thing will be polyuria, polydipsia, and most common will be UTI, because more glucose will be flushing out. There will be chance of developing more UTI because more bacteria will get infected because of the more accumulation of glucose in the urine. Okay. Next, obviously sodium loss will be there. Among these sodium glucose transporters, main adverse effects will be UTI. Advantage will be they won't cause hypoglycemia and weight loss. That's why because of the no hypoglycemia, nowadays we are using more this SGLT inhibitor, that is dapagliflozin and canagliflozin. Okay, that's it. Thank you.